Hi, how are you?
Good. How are you?
Thank you so much for joining us.
No problem.
All right, so we do have a couple of attendees on now, so we can go ahead and get started.
Great. I'm excited to be here. Thank you. Can you hear me okay? Is the volume
Yes,
okay?
yes.
Perfect.
Okay, let me go ahead and just put in the PowerPoint. All right, sorry about that. All right, so let's go ahead and get started. Thank you all for joining us today. We're very excited to do a webinar and just give everyone some information just to learn more questions that a lot of intended parents have. My name is Vanessa. I'm from Angels Creation Reproductive Center. I am a case manager for intended parents. And today I have here the wonderful Dr. Behbehani. She would be our expert answering the questions. Hi, Dr. Behbehani.
Hi, Vanessa. Thank you for having me. So I'll just introduce myself real quick to the people who are listening to this webinar. My name is Sadikah Behbehani. I'm a board-certified obstetrics and gynecologist physician. I specialize in minimally invasive GYN surgery and reproductive endocrinology and infertility. I'm currently at the Center for Endometriosis and Fertility, and I'm excited to be here to answer questions about how we can help women get pregnant and how sometimes we need to incorporate the use of third-party reproduction and surrogates to make this a successful journey for our parents.
Thank you so much. We're very excited to have you. All right, so let's go ahead and get started. We do have a couple of questions. So question number one is, what is the recommended waiting period before beginning IVF treatment?
That's a great question. It can be a very frustrating journey for couples who are trying to get pregnant and expect to get pregnant right away. Most of the time, we recommend that couples try and have regular sexual activity to just see if pregnancy is going to happen on its own before recommending IVF. However, sometimes there are clear indications to go through with IVF before wasting time trying to get pregnant naturally. For example, if a woman knows that she has no fallopian tubes, that her fallopian tubes were removed for whatever reason in the past, then she cannot get pregnant naturally. And we need to help encourage IVF sooner rather than later. If we know that the male partner has had testicular cancer and has received chemotherapy, we know that her sperm may be suboptimal, and it's recommended that they see a fertility specialist sooner rather than later. But in general, in couples who are trying to get pregnant and trying to start a family, we base it based off age. In couples who are younger, who are less than the age of 35, the female partner is younger than 35, then we recommend they try naturally for about 12 months before seeking consultation with an IVF specialist. Just because approximately 85% of couples will get pregnant naturally the first 12 months they try. That leaves 15% of couples that may be unsuccessful at pregnancy after a year, and those are the patients that we will see for consultation to discuss the possibility of IVF. In women who are older than 35, we don't want to waste time trying for too long. So 6 months is the recommended waiting period before they see a fertility specialist. However, like I've said before, it never hurts to see a fertility doctor sooner rather than later. It doesn't mean that you need to jump straight through to IVF, but it's good just to get the tests done with to make sure that everyone's healthy, that everything's going well, because if there's a problem, we want to catch it sooner and either fix it or recommend IVF if that's the best treatment plan for the couple.
Wow, that's a lot of information. Thank you so much. You basically said a bunch of different scenarios, so that's very, very helpful. Thank you so much.
You're welcome.
Okay, question number two. As a 40-year-old, should I consider trying IVF with my own eggs, or should egg donation be a better option? What are the available choices?
That's a great question because this is a very, very common case scenario. We are busy as women with our career, with life, and many times we are not ready to start a family until later. And 40 has now become the new 30. We see women in their 40s, early 40s who are interested in starting a family and they've never had the chance to try before. So how should we counsel them and what should the options be that are available to them? It all depends on their ovarian reserve and how their ovaries are doing, because we know that as women get older, there will be less eggs on the ovaries and the eggs that are present will be lower quality. And so if someone has a really low egg count, then their chance of getting good quality eggs from the ovary may be diminished. But if someone who's 40 has a very good egg count, then it is absolutely worth trying an IVF cycle with their own egg. What we do with IVF is we stimulate the ovaries to produce eggs. We then fertilize the eggs with the sperm, and we check the chromosome combination of that embryo to make sure it's a normal embryo before we transfer it back in the uterus. The reason why we do that is because a lot of women who are older may have eggs that are abnormal in chromosomes, and those will result in an abnormal chromosome embryo that will either not implant or stick to the uterus or result in a miscarriage. The uterus does not age as quickly as the ovaries do. So if someone is 40 and we try IVF and we either don't get good quality eggs or embryos, or we don't get eggs at all, we can always discuss donor eggs. Because if we have a young egg and we fertilize it with their partner's sperm and put it in the uterus, the chance of success will be related to that egg's age. The chance of chromosomal abnormalities will be related to the egg's age. And usually egg donors are very young. They're usually 30 years or younger. And so their chances of having chromosomal abnormalities in those donor egg embryos are very low compared to someone who's 40. But it doesn't mean that everyone who's 40 needs donor eggs. Every treatment plan is individualized based on how they've responded to IVF in the past or based on their egg count, which is determined either by blood work or ultrasound. Some women may be good candidates for IVF with their own eggs, whereas others may benefit from donor eggs. But what's important is to make sure that you are mentally prepared to give up on your own eggs and start your journey with donor eggs. We don't want there to be any regret. So if someone says, I don't know if I want donor eggs, I want to try one cycle with my own eggs first, I think that's absolutely fair and reasonable to see how they would do with their own eggs first. And if things don't look well, then we know that we've tried and it's just not happening. And then we can discuss other options like donor eggs.
Yes, that's really good advice. Angel's Creation does have a very large database on egg donors if it ever gets to that option. So we definitely do offer and can, we do help a lot of intended parents with the criteria that look similar to them. So that can be an option, but again, be mentally prepared. All right, next question. Could you provide guidance on the key factors to consider when selecting a surrogate?
That's a great question. So I do have guidelines that I recommend when selecting a surrogate, just because we want to make sure that whoever is carrying your child is very healthy and fit and is giving your baby the best chances of a live birth. So that surrogate is going to be basically growing your embryo for you. They're going to be feeding your embryo for the first 9 months of pregnancy. They're going to be nourishing that embryo and hopefully helping it grow to its best potential. Some people may be a little more lenient on what surrogates they accept, but I am advocating for my intended parents. I tell them my job is to screen the applicants and make sure that I'm matching you with the best surrogate possible. It is really hard sometimes finding a good match because surrogacy is a long journey. It's very stressful mentally and physically, and we have so many parents that would benefit from surrogates, but probably not enough surrogacy options available. But in general, surrogates should be young. We don't want a surrogate to be older, so surrogates should not be older than the age of 40, and if preferable, not older than 35. Sometimes we increase that age cutoff to 37, 38, depending on how the patient has done previously with pregnancies and deliveries, and depending on their comorbidities. We want a patient to be of normal weight, so we don't want a surrogate to be obese, because obesity can increase the risk of complications during pregnancy. We want a surrogate to have had successful pregnancies, so a surrogate should not be carrying someone else's child for the first time. We want to make sure that a surrogate has been successful at carrying pregnancies in the past. And I do review the surrogacy's pregnancies and deliveries very closely. So we request records from their obstetrician or the hospital where they had their delivery, so we can review their medical history and make sure that their pregnancies were healthy and uncomplicated. For example, if someone had preeclampsia that resulted in eclampsia during delivery, Eclampsia means seizures. That's a medical condition that can recur with subsequent pregnancies. So we don't want to put your baby at risk for having maternal seizures during pregnancy that can affect their viability and their health. If someone had gestational diabetes during pregnancy that required insulin shots and that affected the baby's growth, then we don't want that surrogate to be carrying your child because we don't want your child's development to be affected by the diabetes. We also look at their mode of delivery. It is very common nowadays for women to have C-sections for deliveries, which is absolutely fine. But we know that with every C-section, the risk of complications increase. So the upper limit that's recommended for C-sections in a surrogate is 2, meaning that your child will probably be the 3rd C-section. You don't want someone who's had 3 prior C-section and your child is the 4th, because that increases the risk significantly for complications during pregnancy and delivery. So that C-section scar can open up. It's called a uterine rupture when they go into labor. And during the C-section, it may be very complicated with dense, thick adhesions around the uterus and around the bladder. We also want to make sure that the surrogate is leading a healthy lifestyle. You don't want a surrogate who smokes marijuana, who smokes cigarettes, or who does any illicit drugs. Because again, those things are addictive, and if she's doing them prior to pregnancy, there's a good chance the surrogate mother may continue to use illicit drugs or alcohol or smoking during pregnancy, and we don't want that for your child. So both the agency and myself are very strict with checking and making sure that the surrogates are not using illicit drugs or marijuana, and that would automatically disqualify them for being a surrogate. We also want to make sure surrogates are healthy, that they have no mental health disorders. So if they're depressed, then pregnancy can make their depression worse, and we don't want that for them. We want to make sure they don't have bipolar disease or any mental health disorder that may affect them from making the right decisions, first of all, to be a surrogate, and second, during pregnancy. And so you want someone who's healthy, who's young, who's had prior pregnancies and healthy deliveries, and is doing it because they want to help other couples have children. Most surrogates have children of their own already, and they understand how life-changing it is to be a mother, and they're just doing it because they want to provide that opportunity to other couples who are trying to get pregnant. So surrogacy is a wonderful opportunity for moms who can offer that service and for intended parents who sometimes need that service for medical or health-related reasons. You have to remember that your doctor and your agency are both working really hard to match you with the perfect surrogate that will hopefully give your baby the best chance of success. But just like with anything else in life, there's never a guarantee that the pregnancy will go smoothly. However, our job is to make sure that we've checked all the boxes and given your baby the best chance at a good surrogate.
Yes, thank you so much. And just like Dr. Behbehani mentioned, we are very strict. We make sure that the surrogates meet all these, check off all these boxes before they even become available. Also, you mentioned about the drug, marijuana or smoking. We also do test the partner. If they have one, they have a drug test taken because we don't want anyone in their home doing any of these things. So yes, we definitely are very strict because we want the best journey, process, outcome as possible. Thank you so much. Okay, next question. If I have PCOS, does that mean IVF is my only option for conceiving?
PCOS is very common. I'm sure that majority of women have heard about PCOS. What it stands for is polycystic ovarian syndrome. Not everybody with PCOS needs IVF. That's the simple answer to the question. But the reason why many women with PCOS end up doing IVF is because PCOS can cause irregular ovulation. So women with PCOS typically don't ovulate every month. They may ovulate sometimes, and in some women, they don't ovulate at all. And so options to help them get pregnant typically would include ovulation pills, so pills they can take at home to have natural ovulation and just become sexually active and hope for a natural pregnancy. Or we can do ovulation induction and insemination, where we put the sperm directly into the uterus. If those two are unsuccessful, or if the woman says, I want to get pregnant as fast as possible, then IVF is a great solution. because women with PCOS have an excellent egg reserve or ovarian reserve. They have a lot of eggs on their ovaries. It's just that the eggs are not being released every month. So patients with PCOS that undergo IVF produce typically many eggs to a point where we sometimes are worried that they would overstimulate and produce too many eggs. So we have to kind of watch them closely and make sure they're on an appropriate protocol so we don't overstimulate them. But PCOS is one of the common diagnoses that we encounter in a fertility office, not just for IVF, but also, like I said, for ovulation induction. So if you have PCOS, IVF may not be your only option. There are other options that we can pursue prior to IVF, but IVF will always give you the best chances of pregnancy. It allows us to test the embryos to make sure that we are only transferring genetically normal embryos, which reduces the risk of miscarriage and increase the chances of live birth. And then also for some couples, it may be an important issue, and for others it may not, but it allows us to do sex selection for those couples that want a specific gender. Let's say they have two girls and they're looking for a boy, or they have two boys and they want a girl. When we do the IVF process, we test the embryos for chromosome abnormality. So our goal is not gender selection, but just to make sure that we have a healthy embryo. And then usually we have a cohort, a pool of embryos that may be boys or girls or both, and the couple can choose to have a boy embryo or a girl embryo transferred.
Thank you so much. Have you ever had intended parents that want you to pick the gender?
I have. So I have come across many different situations. So sometimes couples say, doctor, choose the best quality embryo for me and don't tell me. And then I've had couples say, the female partner says, I really want a girl. The male partner says, I really want a boy. And then they look at me and say, Dr. Behbehani, you decide how we should start our family. And it's a tough choice because sometimes the embryos are equal quality. The boy is equally good as a girl. We know that there are more male embryos created through IVF than female embryos. But I always try and respect the family's dynamic and the family wishes. And if they want me to choose, I always have the embryologist choose the best quality embryo. Because whether it's a boy or a girl, our goal is a healthy pregnancy and delivery. And the quality of the embryo can sometimes affect the chances of implantation. So I always refer to my embryology colleagues to help me with the decision.
Yeah, that sounds like a very tough decision. If they were both like a female and a male, were both great quality. All right, next question. Are there any studies on the long-term health effects on fertility treatment?
Yes, so we've been doing this for a very long time. You have to remember that the first IVF baby was born in 1978. So we've been doing this for many, many years, and we've learned a lot throughout the process. We've had the opportunity to do more research on the embryos that are created from IVF and on the pregnancies and deliveries that occur after IVF. And this question still remains an important decision-making question when we're talking about IVF, because couples want the healthiest possible option for their child. And so there are studies that have shown increased risk to the pregnancy with IVF, mostly with multiple pregnancies. So the biggest factor here to consider when doing IVF is the risk and complications associated with the transfer of 2 or 3 embryos. You don't want to be pregnant with twins and triplets because that's where most of the complications occur. The risk of early delivery, preterm delivery, the risk of diabetes, risk of high blood pressure in pregnancy, the risk of the baby not growing well, and the risk of having an intrauterine fetal demise or placental problems that may lead to lack of nourishment to the baby. So our goal is always to get patients pregnant with one healthy baby. So when we remove the risk and complications that come with twins and triplets and look at the risks associated with the transfer of only one embryo or the pregnancy of a singleton baby, we do notice that there may be slight increase in some risks of congenital anomalies, in some preterm delivery, and some intrauterine growth restriction or the lack of excessive growth of the baby. However, the risks are very small, and the benefits of going through IVF and the ability to provide the family with a healthy live-born child usually overcomes all the possibilities of increased risk of complication because the risks are very small, and usually the risks can be managed with the technology that we have available to us in pregnancy and delivery.
Great, thank you so much. That's really good to know. All right, next question. How long can embryos remain frozen?
Embryos can remain frozen for many, many years. Again, like I said, because this is a process that we've been going through for several decades now, we keep learning new things every time. And some studies have shown that it's possible if the embryos are frozen beyond 10 years, that maybe their quality will deteriorate slightly, but not enough where they become non-usable for pregnancy and delivery. So the reason why we freeze eggs and we freeze embryos is because we're freezing your ability to have children. We're freezing it in time. So let's say you are 30 years old today and you know that you're not ready to have children, but you want to make this a possible option for you in the future, then freezing your eggs is a wonderful idea. You're 30 now. We don't know when you're going to come back for your eggs. Are you coming back in 5 years when you're 35? Are you coming back in 10 years when you're 40? If we were talking about 20 years ago, freezing techniques were different than we do today. We used to do slow freezing and slow thawing. And this slow freeze and slow thaw process used to harm the quality of the embryos or the eggs. And egg freezing about 10, 15 years ago was considered experimental by the Association of Reproductive Medicine. So ASRM, the American Society of Reproductive Medicine, used to call egg freezing experimental because we still did not have enough data. But right now, as of today, this is a very standard procedure that we do in every fertility office because we've developed a new technology for freezing and thawing that's called rapid vitrification. So instead of slowly freezing the embryo or slowly freezing the egg, we now put the egg or embryo on a straw, dip it in nitrogen oxide, pull it out, and it's frozen. So it's flash freezing. It's called vitrification, rapid vitrification, no more slow freezing. So that rapid vitrification has allowed us to capture those healthy embryos and freeze them at their most viable stage. And then when we thaw them again, the majority of embryos will be healthy and survive the thaw. If you have a poor quality embryo that's frozen, it will be a poor quality embryo when it's thawed. But if you have a really good embryo that's frozen, it will continue to be a really good embryo when it's thawed. But how long should you keep your embryos or eggs frozen? It all depends on your reproductive plans. Many couples will keep their eggs or embryos frozen until they've completed their families. The downside to keeping them frozen really is just paying the cost of freezing with the IVF office or lab because you have to pay annual fees to keep your embryos frozen. Other than that, there's no downside to ensuring that you have those embryos if you need them. And so most couples, when they feel like they've completed their family, let's say they have 2 children, they're happy with where they are, the children are older, the mother is now older, and she knows she does not want to have any more children, that's a good time to request to either donate your embryos to research, donate your embryos to other couples that are trying to get pregnant. So embryo donation has helped a lot of couples get pregnant when they don't have good quality eggs or sperm or both, or discard the embryos. That's a personal choice. You decide what you want to do with them. But I always recommend keeping your embryos for as long as possible until you are absolutely certain you don't want any more children, because you're never going to be the age you were when those embryos were frozen. We cannot go back in time. And so if they were frozen at your prime reproductive age, at 30s, early 30s, late 20s, those embryos are precious. You can use them when you're 40. Some women say, okay, let me freeze my eggs, and then I want to try and get pregnant naturally when I meet someone. That's absolutely possible. And if that doesn't happen, then they go back and use their frozen eggs. So we have lots of ways to incorporate those frozen gametes into your reproductive plan. We can either use them for your first child, your second child, your third child. And then when you're done with having children, you can decide if you want those donated to another couple that are trying to get pregnant, discarded, or donated for research.
Perfect. Thank you so much. All right. Next question. How long does the egg retrieval process typically take?
That's an excellent question because a lot of women have this misconception that if they do IVF or freeze their eggs, it's going to require a big chunk of their time. It's a lengthy process, but it is actually not. It is a very quick process that gives us a lot of important outcomes. In women who have regular periods, we usually try and time the start of their cycle with their period. Some women may benefit from birth control prior to their period. Some women may benefit from estrogen pills or some sort of priming to help increase the response to IVF. But typically, the IVF process, the start of injections, will start with your period. Most women need about 10 days of injections before they're ready for their egg retrieval. And then the eggs are retrieved 2 days after the last injection. So that's literally 12 days of injections and you're done forever. You don't need to come back. No more procedures, no more ultrasounds or follow-ups. So it's a very quick process that you can definitely incorporate into your daily life. Women go on vacation all the time because we want to have fun. We want to enjoy our time away from work. But sometimes instead of doing that annual vacation, maybe allocating the time to do your IVF cycle and freeze your eggs, or if you're ready to get pregnant, even create embryos, I think is equally important.
Absolutely.
What I was also going to say, let's just go back to that question real quick. I'm just getting notifications on my computer. So what I wanted to say about that as well is the egg retrieval process is quick. So even though I said you need to take injections every day for 10 days, you're literally in the office for about 15 to 20 minutes every 2 or 3 days. You're not here every day. You come in for a quick ultrasound, you do blood work, and then you're ready to go about with your normal activities and come back in 2 to 3 days. You don't need to be here every day. You're not going to spend the entire day at the doctor's office. Quick ultrasound, blood work, go ahead and do your normal activities. It's only on the day of egg retrieval that we require you take the rest of the day off because we want you to feel like you're giving your body its best chances at recovery. You've invested so much time and so much effort in this process that it is worth giving your body that time off to recover and heal from the process. But just the day of retrieval, then the following day you're back to normal activities, back to work.
Great. Yes, it actually is such a quick process. A lot of people don't know that.
Exactly, and that's why I'm saying it's very easy. You shouldn't feel overwhelmed or intimidated by the process. Your doctor will definitely describe all the steps when they see you, but just think about it. It's literally 2 weeks out of your life that can guarantee you the presence of eggs for later when you're ready to start a family. So it's like a backup security blanket to fall back on if you need it.
Yes, absolutely. All right, next question. After egg retrieval, how soon can the intended mother undergo embryo transfer?
Okay, so if we are talking about surrogacy, then this step is considered a 2-step process. One step is stimulating the egg donor, whether it's the intended parent, sometimes it's the mother that's producing the eggs, and then putting those embryos in a surrogate. Other times, it's the egg donor that's creating the eggs, and then the intended parent is the mother that's carrying the pregnancy. But even if it's the same patient doing an egg retrieval and a transfer, it's always a 2-step process. One step is creating the embryos from the retrieved egg, and the next step is transferring that embryo back into the uterus. So the egg retrieval process we talked about, it's quick. 10 days of stimulation, you do your egg retrieval. On the day of egg retrieval, your job is done. But the lab needs to start its work, and that's where the magic happens. So those eggs are cleaned, they're stripped, they're checked to see if they're mature or not. The sperm is injected directly into the egg, and we watch those embryos grow in the lab. The embryos need to grow for at least 5 days until they reach the blastocyst stage of development. The blastocyst stage of development is the development of a mature stage embryo that can be biopsied to check its chromosomes. We have to check the chromosomes of the embryo before we transfer it because we want to make sure we're transferring a normal, healthy embryo. And so 5 days for the embryo to grow, biopsy, and then the biopsy results usually come back 2 to 3 weeks later. So we cannot do a transfer right away. We need to pause, and that's why the embryos are frozen. We wait for the results. We get the results usually about 2 weeks later. And then based on the results, we have a discussion with the intended parents. We have X number of embryos. Are you ready for transfer in a surrogate, or do you want to bank more embryos? Because some couples say, if we have only one or two, maybe that'll give me one child, but maybe I want to have 2 or 3 children. So let's keep going and banking and creating more embryos. So we can definitely do that until we're satisfied with the number of embryos we have. And then we start the transfer process. The transfer process is also very simple and quick. First of all, we need to check the cavity of the mom that's going to carry the pregnancy, make sure there are no polyps, no fibroids, no infection. Once everything is cleared, then we need to prepare that lining of the uterus for transfer. And that typically involves the use of hormones. So women need to go on hormones for approximately 10 days. So 1 pill 3 times a day for 10 days. Make sure the lining of the uterus thickens well. So we do an ultrasound. And if everything looks good on the ultrasound, then we start the next medication, which is progesterone, to help make that lining sticky and receptive. They take that medicine for 5 days, and then we do the transfer. So again, in total, about 15, 16 days to transfer. Once we do the transfer, then we consider the mother pregnant until proven otherwise. But that time period between completing the egg retrieval to performing the transfer is very variable. It depends on who the transferred embryo is going into, whether or not they were screened already and checked with the hysteroscopy to make sure their cavity is normal, and whether or not they've completed all the required blood work. But if we are doing it quick, if we're trying to do it as quick as possible, then we need at least 3 weeks in between to get the genetic test results, and then another 2 weeks to prepare the surrogate or the person who's carrying the pregnancy for a transfer.
Yeah, that's actually not a long wait at all.
Not a long wait for couples who've been struggling for a really long time. And honestly, once the embryos are created, it takes off a lot of the stress. Knowing that your babies are there, you have them. We just need to find the right person and a good time to put those embryos back into the uterus.
Yes, that's true. Once the embryos are created, I'm sure the intended parents feel such a relief, because that's the most crucial part, besides like carrying the baby for a while. But yes, that's very, very good information. Okay, next question. Is there a specific checklist or set of preparations required before starting IVF?
That's a great question. So women always ask me this: what can I do to increase my chances of success? What can I do to make this a perfect cycle for me? I always tell them, first of all, take care of yourself, take care of your well-being, and that will be reflected in your eggs. So make sure that you are feeling good about yourself. Go for that walk that you love doing. Do that exercise class, that spin class, go to Pilates, whatever makes you feel better about yourself. Diet and exercise are very important for mental health being. Make sure you're eating well. Don't eat all that junk food, all that fried food. It's not going to make you feel well about yourself. Eat healthy, do exercise regularly, but also consider incorporating other activities to help reduce stress, such as meditation and acupuncture. I always recommend meditation. That's simple, that you can do at home on many free apps that are available online. You have the time and energy for the lifestyle, and that would be even better, because acupuncture has been scientifically proven to increase chances of pregnancy. So I always recommend acupuncture for women who can go through with it. Some say, I'm so busy with my day, I barely have time to show up here for my doctor visits. Then not worth it. We don't want to add more stress to your day. But if it's relatively easy, then consider acupuncture as part of the journey. Prenatal vitamins are very important. Also talk to your doctor about what additional supplements they may recommend to help improve your egg quality. And then go in it with a positive attitude, because feeling good about this process will give you good results. Feeling negative may give you negative results. It has been shown to impact success when someone is visualizing that successful pregnancy. I actually had a therapist once that was working with my patients that would tell them, buy small items that you want to gift the baby later. So buy a little onesie, buy a little cute hat or mittens, and put them up on the wall right in front of you. Every morning when you wake up, look at it and imagine or envision your child wearing that hat or wearing those tiny mittens. And that helps create a connection between you and the child that's not yet there, but we're working on making happen for you. And once you're doing your embryo transfer on the day of transfer, visualize that again. Think about all the cute things that you're going to see your baby in. Think about that baby growing and implanting in your uterus. And all those positive thoughts and positive behaviors will hopefully give you better results.
That's really, really nice advice. And I know naturally, women get stressed and men get stressed because they are going to start the IVF. So these are really, really good things to do during that time, especially the meditation.
Yeah, so do whatever works for you. Everybody is different. What works for you may not work for someone else. Just do the things that make you feel happy and make you feel good about yourself.
Perfect. Okay, last question. Do you have any suggestions for parents who are beginning their IVF and parenthood journey?
I won't lie to you. It is not an easy journey to go through, but the outcomes and the results are magnificent. They are so worth it. I know how long you've been struggling with infertility. I know how long you've really wanted a child. And so to see that dream actually become a reality is absolutely worth it. A lot of couples feel financially stressed over the cycles as well. But people put that money for a college fund to give the children the best chances at success. Let's start with having that child first and then work our way back into creating that fund to give them a successful cycle. So every dollar spent on this journey will hopefully be worth it once you have that little baby that you hold in your arms. Make sure you connect with your partner. A lot of couples feel that this IVF journey is making them drift apart. It's not helping their relationship because they're stressed. Some cannot be sexually active because they're going through treatment. So many doctor's office visits, so many injections to do. So all of that adds stress to the relationship. So make sure that you are talking to your partner about it. Make sure that you're both on the same page. Make sure that they know how stressful the situation is for you. And if you need it, then hire a coach or a therapist that can help you through that journey. There are fertility coaches available now that will help women with phone calls, sessions on Zoom throughout the process to make sure they're comfortable and feeling ready for each step, or even a therapist that you can get through your primary care doctor to help you through with your stress and your emotional roller coaster that this journey will take you through. But make sure you have someone to talk to. If not a therapist, if not your partner, find a best friend, a close family member that you can talk to. If that doesn't work out, support groups online. There's so many support groups online that can help you through this journey, people who've gone through similar experiences. But please don't try and do it alone. It's too stressful. And we want you to feel encouraged and feel good about it. And so again, thinking about the outcome and the results of having a little baby to take home at the end of the day makes it very worth it. And please don't rush the process. I know we want to get pregnant yesterday, but rushing usually results in us making shortcuts that are probably not to your benefit. And so take your time. Go finding the right doctor for IVF. Take your time finding the right surrogate that would be a good fit for you. And then I have hope that the universe will help you with your goals and everything will line up. And every couple who desires a child hopefully will be able to take a baby at the end of this journey. Sometimes we just have to be a little creative.
Great. Thank you so much. That's great advice. Thank you so much. I really appreciate all your time. I know you're busy.
You are very welcome.
Yes, thank you so much. If any of you are interested in seeing Dr. Behbehani, we have her information. We can refer you over to her. She's a wonderful doctor. We really, really love her.
Thank you. And I like working with your team as well, Vanessa. Thank you for having me today. Enjoy the rest of your day, everyone.
Thank you too. Bye.
Bye.